CAOT acknowledges the enduring and vibrant presence, culture, history, and inherent rights of First Nations, Métis, and Inuit peoples across Canada, on whose traditional territories CAOT's members and staff live and work. Welcome to OT Conversations That Matter, the podcast. I am your host, Justine Jecker, joined today with Health Systems Educator Sean Fisk and Community Mental Health Director Gord Unsworth to talk about substance use health as a primary tool to dismantle systemic stigma. With our current addictions-only model, we continue to ask people to get sicker before healthcare is available. We focus on an illness-based model rather than the health of the greater population, categorizing and othering people for their illnesses rather than creating supports along a spectrum of health. Over 80% of people living in Canada use substances, yet we continue to leave them out of the conversation and out of our healthcare system. Health is the through line in this conversation involving substance use, substance disorder, and the substance use health spectrum. Sean Fisk is an engaging educator, clinician, facilitator, and public speaker whose professional expertise is informed by more than 20 years of experience accessing systems of care for substance use health and mental health needs. With a strong background in peer support, community outreach, and clinical service, Sean has been instrumental in developing programs that reduce stigma and support individuals facing substance use health challenges. As the education and partnership lead at CAPSA, he focuses on improving health outcomes through program design, strategic partnerships, and collaboration with healthcare and community organizations. Sean is committed to aligning services with community needs and to advancing systems that deliver compassionate, responsive care. Gord Unsworth became an occupational therapist after receiving his Master of Science from Queen's University in 2007. Gord is currently a director in community adult mental health at Providence Care in Kingston, Ontario. He has provided individual and group therapy assessments, consultations, and education as a clinician. Gord has worked in hospitals and in the community and continues to demonstrate his desire to be a leader in healthcare. Gord has also been an adjunct lecturer and clinical supervisor with the School of Rehabilitation Therapy at Queen's University since 2008 and continues to enjoy contributing to the greater community through his work at Queen's University and Providence Care. Welcome, both of you, to the podcast. It's such a pleasure to have you here today.
It's good to be with you, Justine.
Yes, I am excited to talk about this taboo issue. When you reached out, Sean, you were full of statistics and information, and you kind of had me at hello. And in our opening today, we start with this pretty large number, this idea that 80% of Canadians use substances. Can you get us started in sharing a little bit about what are substances and why are so many Canadians engaging in this?
Well, really, it's a matter of individual agency and personal autonomy. I think substances is part of the human experience, but it's part of the Canadian experience. And so when I started talking to you, and I didn't want to sound like a politician spewing out, statistics without grounding in what we know in terms of evidence and practice-based evidence, but the idea is that we know that something like 78 to 84% of people use substances regularly. That's not just alcohol. Right, this is self-disclosed as well. And so what we see is that there's a special narrative, though, for people who use substances that experience a disorder. And that special narrative is, that illness-based model that's not really a health-based conversation. And we can get into a bit about that around the differences between mental health and substance use health in a bit, if you like. But just to say that, there's a matter of health equity at hand. So the through line, as you were saying in your wonderful introduction, is health. And so why then is there only a health-based conversation at the primary care level, at the hospital and institution level, even at the knowledge and information level, why is there only a narrative for the something like 4 or 4.4% of people in Canada who will ever experience a disorder? Where is the healthcare knowledge, information, and supports? Where's the health promotion for that, 96%, let's say? And so as a matter of health equity, unless you have quote unquote an addiction, substance use disorder, you've now been excluded from the conversation around substances and health.
That's incredible. It's such a huge number to take that jump from 4% to 80 or 90% of Canadians and all the people who might be overlooked in the process in the healthcare system, who are engaging in substances. Gord, I know that this has probably been part of your journey as a clinician for the last couple of decades. How has it been for you in learning about substance use with the people you're working with?
Well, I think just building off first to what Sean was speaking is when there's, say, we'll say 80% of people use substances, we have to think about that for our OT practice as well, that also transcends to the people that we work with, probably higher than that as well. And so we need to consider that when we interact with people, whether it's a client or a family member, that substances is a part of our work. But I think what we need to do is to actually be aware of this, identify it, and then act. And so it's been a part of my OT journey that I think until recent wasn't a part of my practice. So trying to park it aside. But if we think of being an occupational therapist, being client-centered, following a person like in a holistic sense, that's been missing in my practice. And so Sean has really encouraged me in the last year to think differently and to increase my awareness that everybody has a story. And as OTs, we don't have to have all the answers, but if we can partner, listen, and also share the level of expertise, then that could really change the work that we're doing. And so for me, being on this podcast, I'm grateful and I'm excited about what we could accomplish together as OTs, as humans, as community members. The sky truly is the limit.
Yeah, it is very humbling. I know when Sean reached out, even just using that word more intentionally, substance use health, like I really, maybe I'd heard the term, but I hadn't really thought of it so thoughtfully. And I agree, Gord, in my practice, it's almost like this happens alongside you being an occupational therapist, as opposed to it being directly part of most clinicians' practice, that you come with that lens that probably most people who are sitting in front of you are using some form of substances. And I think that getting comfortable with that language. And the other thing, and I know, Sean, you have a lot to say about this, but the clumping of the idea of substance use and mental health, how that's become like this indistinguishable, it's like one or the other. You can't, if you're talking about mental health, you're talking about substance use. What are your thoughts on that? Are these separate things? Should we be treating them separately?
Well, there's certainly a lot there, and we'll talk about it just from a funding perspective or a systems perspective just for a moment, and maybe then get granular. To start off, we're looking at something that's often been referred to and long too often as the poor cousin of mental health, right? It'd be mental health ampersand, right, and addictions. And so that's an old trope in the addictions sector, what we prefer to call the substance use health sector now, that this is a poorly funded afterthought. But I
Mm-hmm.
would just say that it doesn't cost us anything as an organization, as people, as a system, to add the word health at the end of the phrase substance use. And so around the halls at CAPSA, we have sort of our own type of humor where we say substance use services. Oh, isn't that the LCBO and other like-minded organizations? Why not about my health and wellness? Why not about our community's health? Mental health, of course, is now long since understood through a continuum-based perspective as something that comes and goes, that we experience throughout our life. We may have symptoms that are clinical or subclinical, and that's a common reality for people around symptomologies for things like mood disorders or anxiety-related disorders. And when I teach children, kids in grade 5 know all about this, and it's very, for lack of a better term, it's very socialized or normalized within our vernacular in a really positive way. We have Bell Let's Talk, et cetera. Around substance use, we just have sickness or completely healthy. And one of our
Mhm.
larger studies that we did with CAPSA, with our partners at CCSA in Canada, showed that, a plurality of people in our country, higher than 75%, believe that you are completely healthy or completely sick.
Wow.
And so there's no gap there. We have, a high amount of people, 68 to 75% of people don't know where to go to support their substance use health if they don't want to quit. And so in terms of trying to pull it out from underneath mental health, one of the ideas is that we know that substance use is such a common part of our health-based conversation, yet it is so poorly funded. Part of our work at CAPSA, especially at the higher level, is looking at something like a mental health and substance use health parity act. We'd like to see some more funding out, because anyone that works out there that's listening in the addiction or substance use disorder, substance use health field knows that it's a very distinct and specialized perspective and a specialized field. And so I really would like to pull that out. But again, building on the strength of the last 30 years when we had a mental illness model to the mental health model, we're looking to do something quite similar. And that's how we pull on those lines and push down those walls that we would call systemic stigma or social or public stigma, as well as the self-stigma people experience around substance use. And the way to do that is to bring health into the conversation.
Yeah, that's an incredible journey. Normalizing now we can openly talk about mental health, right? We can talk about mental wellness, and we can take a mental health day. We don't have to explain what that means. That's happened in my career, to see that shift happen. And I think with the word substance and substance use health, that is an incredible thing. I think as a society that we should be shooting for, is understanding that this is a practice, it's an occupation as occupational therapists that we should be looking at. And I wonder, for you, Gord, what was the first step? What was the first step when you were realizing, okay, I need to more intentionally either ask questions or even just open the door for conversation around substances?
Yeah, I think that's a key question, and thanks for asking that, Justine, because we have many listeners that are thinking, well, what could be my next step, or what can I do? And so I think I've had to just reflect and realizing I need to change how I sit with people with their health. And I think it's beyond just mental health and substance use, but what is a person bringing in the room and how do I respond? And so I think we can be a bit more curious with people and their life journey and where they're at, then that can be freeing. So not thinking I just need to ask this question or that, but let individuals express what matters to them. And then we can say things like, thank you for sharing that with me. What's that like for you? How is this working for you? How is this impacting you negatively, if at all? And so I think we can continue to kind of embrace people where they're at. And I think the thing that's been really freeing for me is substance use health. We're all on the map. So learning from Sean and the information about substance use health, on the continuum, there is no use or not currently using, all the way up to substance use disorder. So that puts us all on the map. So from an occupational therapy standpoint, as we intervene with individuals, regardless of what their substance use health is, we can have conversations. And so what I've done in the last 6 months, Justine, is I've partnered more with Sean, and I'm talking about it. I'm promoting it, having discussions. I'm on the podcast. I've also gone to a nursing unit locally to talk about substance use health, and to talk with nurses and other care providers to say, share information. And I think the other thing, when we're doing something that's relatively new, is to take some chances and to speak about it. So I think sometimes in healthcare, we feel like, okay, I need to take 6 different courses. I need to have a certificate, but that's what's actually set us back. We actually have to focus on the human element. Something I've learned from Sean, it's kind of weird, talking about this, because Sean, you've taught me so much in the last year, but things like take a step in. So if somebody shares something, we're better to take a step in and embrace the person. I think sometimes in healthcare, we've made it where people are afraid to say things and that there could be repercussions. So let's all together take a step in to meet the person where they're at. We could do that we're a step ahead in providing the best care.
If I could just build on that, Gord, because now we're talking, Justine, we said maybe the larger system picture. Now we're getting granular, which is where my heart's at. I'm sitting with a human being. So why is substance use health at that level the primary tool to dismantle systemic stigma in a personal way? Well, because we find that caregivers often don't take that step in. Hey, Gord, they take a step away. It's a lack of understanding, a lack of knowledge. But what I find in my work across the nation, it's that people have a hard time seeing themselves in me and me in themselves when I'm presenting with an illness or disorder around substances. Knowing that that's not the most common experience for people who use substances, still it's what we think of. And so when I'm sitting across the table from a first responder who may have helped me around a medical emergency, or if I'm in a hospital, or if I'm at a clinician or an OT's office, sometimes we see those who have substance use disorders or even substance use challenges, wherever they land on the spectrum, we see them as a different category of person, and we don't see them as the same. And so one of the ideas of the spectrum that CAPSA created was the substance use health spectrum is a health-based tool to do something like put us all in the same category. One of the things that comes to mind when I say this, and I work really deeply on allyship, which means I don't want to stand in front of someone's story, but as I go across the north in Ontario, say specifically as an example, speaking to some of our Indigenous partners about substance use health, often I get a nod and say, oh yeah, that's the same as Indigenous harm reduction. And I say, oh, what's that about? And folks will tell me we're all inside the same circle. And I remember hearing that distinctly and thinking that's wonderful language. And once again, even though we think we're very new around our substance use health spectrum, turns out people thought about this before, eh? So good lessons in that.
Yeah, and I love that the word spectrum is incredibly powerful, right? In the language you're using, that we're all in this circle, we're all in this place, but we've created, as therapists, we're taught, to create the distance, right? To not give too much of yourself away, and we're shifting more into a time where positionality is becoming part of the repertoire of therapists to be able to position yourselves. And it's interesting, if we bring this to a really granular, practical level, how does an occupational therapist who wants to connect with somebody, who wants them to say, I might not have walked exactly in your shoes, but I do have some experience myself. What has that been like for you, Sean, in terms of what has been a good interaction with somebody who's been able to position themselves with you versus somebody who didn't take that step in?
So there's a lot there. First and foremost, one of the things I like to offer is a different view of empathy. So sometimes we think of empathy as we are walking in your shoes, or I understand you, or I even relate to you. And that's really missing the mark from my perspective. Empathy is that moment where we have an emotional intelligence to listen to an experience someone is telling you about without purposefully or accidentally laying claim to their experiences. Meaning, I don't walk in someone's shoes, though that's their shoes, right? And so this idea that comes up a lot. And so that's where people tend to miss the mark, and they take a step in, but then they get just a little too close and they make it about themselves. And I would often, when I'm mentoring clinicians, I ask, when did it become about you and not about the person you're caring for? And when you cross that invisible line, I think we've gotten into worrying about things that aren't really fundamental, important things about caregiving. So there's been that piece has been really important. But in terms of the sort of creating what we like to call safety and understanding in a moment of support, one of the ways I like to look at that is that when I'm sitting with someone and they know that there is nothing they can say that will have me bubble up a feeling or communicate to them that I'm disappointed in them. When their experience is their own and I'm sitting with them and I can say to them wholeheartedly, you will never disappoint me. I'm just here with you. When someone knows that feeling, that's when we can start to workshop wellness together. And so there's a lot of things that are barriers to that, Justine, the feeling that we empower others or we lift them up. There's feelings of heroicism. There's also feelings of imposter syndrome, right? Like, if you care for me, I have to get better, or your caregiving isn't valid. There's all these things in the way. What I will offer, distinctly coming from my perspective and from the in-community peer world, is that stuff's really pushed aside for the way people formally gather outside of the healthcare system to support each other. And I think the healthcare system could learn a lot from this experience, which is, I don't chase you down the road to make you well. I don't I don't look at the criteria of my own wellness through the lens of whether someone's symptoms go away or not. I'm just there in that moment, taking, as Gord said, one step closer. So in mentoring people that way, it's gone well. In my own caregiving as a clinician, people usually ask me the same questions, right? Do you have these experiences? We're taught to say no, but I always say, I'm not a listener. So I always say, yeah, of course. So how can that help you? And people will say it creates safety to know that I've had these experiences. Controversially, I will say, I don't think that's a great thing. People who come for care should be the same exact safe with everyone. And so we need to take that peer wisdom, as we might call it, and bring it into all caregiving, particularly OT, as well as clinicians, as well as in the distinct medical sector.
Yeah, and it's
I have a
go ahead, Gord. Yeah.
I was just gonna add a bit on that is, for me, empathy is not my favorite word for this. It's more, and for the listeners, I'd have you consider presence. So truly being with the person. I also like to use the word witness, or to listen with a capital L. And so to take a step in isn't about my experience with substances, but more so what is their substance. And then to Sean's point, there's times where there might be shared experience, or that the person you're working with might have some questions. And so we want to embrace a person where there's that. But I think our task as OT is all over the country and across the world is to think about what is our relationship with substances, what biases have been created through our own experience or with family members or past clients. So that's the work that we do before we have a conversation with a person, is understanding how have we come to this place today, but not having that be central in our interaction. So the step forward is to really be there with the person and understand them like no other in a client-centered fashion, and then using, therapeutic use of self as needed, but not have that be at the center. And so when we do that, then I think we can really connect and take that step in and make it where people want to share and grow versus, I love, Sean, when we talk about outcomes, that there's a need for outcomes, but the primary outcome is actually connection. That's what we need to do in everything that we do, whether it's something to do with substance use health, but with other people need to be heard and valued. And so, yeah, for years, the word empathy doesn't really resonate with me, because it then becomes understanding my story and how it relates to somebody. And we're using like I more than focusing on the person.
Yeah, and I think that this is beautiful. I am imagining, sitting in front of someone who I'm just meeting for the first time and starting this conversation and going back to that word substance. Like, what is it that we're actually talking about, right? If we look at insurance companies, and anybody who's called for life insurance or any form of insurance will be well familiar that it's very binary. You're a smoker or you're a not smoker. There is no, you smoke one cigarette a week. You're 3 packs a day or nothing. You drink or you don't drink. And they might have a little bit more of a spectrum with that one in terms of how many per day. But when it gets to using, illicit substances, it's just this massive category that again, it doesn't matter if where you are on the spectrum, you're just put into one box. And I feel as you're both talking about, there's that humanitarian component of working with the person in front of you and also being really aware of, okay, this is the system. The system sees this as a black and white thing. And there really is, I feel like that's where the key work is for therapists from the advocacy perspective. Be human beings with your clients. And now you really got to get to work with the system and how to make that system more flexible and more reflective of society and everyday life, not just the 4% or the 95%.
Yeah, around here, Justine, we call that community driven or community led indicators. What is important from the perspective of individuals who are facing, say, the healthcare system or facing research or facing systems is very different than what seems to be important from those within the system looking outwardly, right? So there's two sort of views there. Now, the really complex part, and germane to the work I do with CAPSA, is that many of us are both. And so there's a binary for you again. I am either a healthcare provider or I'm someone receiving healthcare around substance use. or in substance use disorders, substance use health, but that's not really a realistic snapshot. I'm many things, as most of us are, but we tend to separate. And so that's where we start to see the signs of what stigma, which is, in its essence, discrimination, right? That's where you start to see the signs of it when we're othering people and categorizing them according to that one thing. But yeah, the system level stuff is quite complex, right? Because we start to think about the difference in gaps of knowledge, information, and research, as you're signaling, between something like alcohol use and something like another substance, and the judgment around that. And there's a class conversation around that. And we see the in-between part in our country right now, which is cannabis, right? So cannabis is a complex ball
Everywhere.
too, because it's highly unregulated. Clinicians aren't sure what to do. Cannabis use disorder is a thing that's not seen to be a real area of necessity or support. We don't have a lot of information in terms of the rest of the spectrum around cannabis use. For instance, we don't know what a standardized dose is, so people are not able to make informed decisions around cannabis use, especially for our youth. And again, not coming from a space of temperance or anything silly like that, coming from a space that there's a gap in knowledge and information, and that signals complexity when we're trying to enter the healthcare system if we don't want to stop using, which is the more common experience again. And that, of course, leads us to the really complicated system piece, which is the prioritization of abstinence as the main success metric, and how, let's just say, othering that can be, right? So it signals to one wellness pathway as the accepted one, and the rest of them are, as we're seeing in our province and country at the moment, are considered to not be as important, right? And we need to acknowledge that people find many pathways to wellness, and that also many people who experience a disorder around one or more substances in their life return to using substances again and find themselves on a different spot in the substance use health spectrum that is not the disordered piece. And I'll just tell you, colloquially, when I say that to clinicians, smoke comes out their ears like I'm saying something they can't compute, because we're so ingrained to believe, oh, if someone had a substance use disorder, they can never use substances again. But that's the mark of shame and indignity. That's stigma that tells us that. So there's a lot of work to do. I agree, Justine, on the system level. And that's why, the work that CAPSA and other organizations are doing, CAPSA at the forefront of it, or tip of the spear, so to speak, is so important, because we're shining light on these issues from a blended expert perspective, where those who have lived and living experience accessing systems of care for substance use disorders, but we're also a team of professionals. And we say, guess what, everyone, we're both. And we're bringing these ideas to the forefront, and we do it in partnership with folks like, my friend Gord, but also in terms of the institutions he works at, like Providence Care, one of the mental health partners, or our ability to connect with the Queen's students, OT students as an example, where we do things in partnership to bring that knowledge and information across the sector, which is so important.
Gord, I'm thinking of from our occupational therapy field. I did a little Google this morning on our COT Find an OT. So we have, there's approximately 11,000 of 20,000 occupational therapists that are members of CAOT. And we do have a voluntary Find an OT directory, which does list substance use and addictions as an area of practice. And we only have 182 profiles of OTs currently listed. So it's huge just seeing that number. I felt, if somebody is looking for care, if they're looking for support from an occupational therapist in this area, what message could we be giving people? It may be to our fellow colleagues first, and then maybe to the public in terms of where can they get support?
Yeah, I think those numbers are really interesting. If we look back to the start of this podcast, saying that 80% of individuals use some type of substance or have experience with it, yet only, sorry, it was 100 and what was it? OTs?
It's 182 that are listed that they would be willing for someone to reach out to them. Not to say more OTs than that could be addressing substance use and addictions, but those are the ones that it'd say, yes, you can contact me for a referral.
So I think what I would say first, before we look at what the public can expect, is challenging the OTs that are listening to the podcast I think there's the system level changes we need to make, but I think that could bog us down. And so let's look at one client at a time. So each person that's on the call, if we could all make changes in our practice where we're more receptive and maybe aware that we can intervene in a client-centered, solution-focused, caring way that puts the client at the center of their care, including substance use health. And so I think the one thing I would say, the 11,000 OTs with CAOT or the 22,000 that are across nationally, is we can all make changes. I think it makes me think back to when I started practicing in 2007. I was kind of upset with the stigma of mental health, and it was almost overwhelming. And so back then, I don't have a date, but I thought I'm going to focus on today and be the best OT possible and really try to lead the charge by one person at a time. Whoever I'm working with on the in the hospital, whoever's in my office, whoever I'm talking with. So I think that's what we can do as OTs is let's make individual changes in our practice by asking questions, listening, or also by engaging with people like Sean as far as bigger educations and more training. Makes me think I think I had an incomplete thought where I was saying we often think we're 6 courses away in a certain certification. We all have lived experience as far as I have a relationship with substances today, yesterday. We all have family members. And so let's not think, okay, I'm a novice in this because we have more experience than we give ourselves credit for. So let's move it from a system level for all the OTs listening to this. What can I do today to elevate this work and also be a more client-centered OT? And then as far as for the public is, I would say, let's continue to talk about it. That's the homework assignment for all of us is let's bring our whole self into the care that we provide. And I think if more people, whether it's community members or staff, can also identify substance health needs, then we could change that profile. And maybe, Justine, it looks like in future years, CAOT, there's more offerings of substance use health, or it could be more just the smaller details in the day-to-day that we're talking about it in our practice. We're reflecting about our own experience, and it's also then changing like the organizations that we work with. So let's start kind of like at at the grassroots level or in our individual practice.
Mm-hmm.
Community's health is such a easy conversation publicly to think about. And if we just consider that from that perspective, our sign says our community, all of us health, and we're holding that sign. That's an inviting, inclusive conversation. In terms, again, what Gord's saying, in terms of sitting in an office with a human being, destabilizing us and them and making it a we conversation instead is so important. But maybe I can share an experience in terms of your young OT students. I had the privilege, as I was saying, to speak at Queen's to Gord's class. It was a large class. And, often when we talk about systems, we start to get a little despondent, big numbers. And Justine, I've got lots of those, of course. But one of the things is around these numbers is you start going, uh-oh, in Ontario, as an example, we have something like 30% of the health workforce is about to retire. We're concerned about replacement numbers. We have people going off on all sorts of fatigue and burnout, and we're trying to address those ideas. How do we remain healthy while helping others? And so that stuff can weigh heavy on the heart, eh? The system is broken talk, right? And I like Gord saying, what's an action today? Well, just a nice story that I experienced when I went to his class was an incredible group of engaging people. And they were asking deep and interesting questions about, clinical scenarios, support scenarios. And I really remember leaving, and I said something similar to this to those folks, and then, tried to make a bit of a splash on social media about this, much to no avail. But the idea is, wow, what a bunch of engaging human beings. The future can be bright in terms of healthcare. And for me, that was a real snapshot into what occupational therapists could do.
Yeah,
There
no, it's so energizing, and it's true. You hit the nail on the head, Sean. When you're in numbers, it's so powerful. The brainstorming, the humanity, the feeling like we can do this that comes together. I think it's when you're alone that you've inspired me to share one of my clinical examples from back in the day. But working in Thunder Bay and in northwest of Thunder Bay, FASD is very prevalent, both diagnosed and suspected or undiagnosed FASD. And not just from alcohol, but there's a variety of different conditions. Individuals experience with either drinking Listerine, sniffing gas, use of different substances that if you're in urban settings in Canada, you're probably not even thinking about. When I first became exposed, I was trying to think like, yeah, what can I do as an individual? Because this is really community. This is a community experience, and nobody is really choosing to do this. There is clearly a beginning of this story, and this is kind of where the domino is ending. But I was really inspired by a leader from the United States, Jody Allen Crow at the time, who was doing, he called it beginning the journey workshops, just to, and it was really focused on destigmatizing and really just acknowledging creating a safe and open space to talk about, this is what the community is experiencing, and allowing them the opportunity to put in their words. Because I think what's also a barrier in the clinical medical world is all the labels and all the words that we're using to describe this experience that's very personal, and it could be associated with trauma, it could be associated with many things, but we're almost telling people what it is that they have, as opposed to really just saying, okay, how would you describe this in your words? Like, what is it that we've called it a substance use disorder, but the community actually sees it entirely different. They see it as, well, we're really hurting and we're in a lot of pain, and that's what we call this.
And I really love that because who's the expert in the room? And sometimes I tell clinicians we're looking for a new and different experience than we've had before. And just personally, I was able to feel very supported and cared for when someone spoke to me in plain language. And what mattered most to them was the language that I used. So as a young budding addiction counselor at the time, right, you start learning, I'm going to sit in a group, and I'm going to teach on my little board, what is addictions? And you realize early on that if you just ask people, what are you experiencing? And you write those words on the board, boy, you learn a lot, eh?
Oh my goodness. It's I'm so glad that we created space in doing this, Sean. This is our 60th episode of the podcast, and we have had one previous looking at the occupational therapy identity and mental health, which covered a little bit, looking at opioids a little bit in that episode. But I'm really grateful that you and Gord joined today to talk about this. I do think that for our profession, we are beginning our journey professionally, moving beyond this being an area of practice to being a professional responsibility for all occupational therapists. Just in our final minutes of the podcast, I want to give you each an opportunity to share, what do you think our listeners should take away, whether it's a resource, a thought, or maybe an action that they can engage in following the podcast? I'll hand it to you first, Gord.
Yeah, thanks, Justine. I think it's such a nice idea, and I think that's what I would be the take-home message and happy 60th podcast would be, how can we shift from this being an area of practice to a part of our practice? And so I think I've already mentioned this throughout the podcast is, let's all take a step forward today as OTs, that this is a part of our practice. And I think it's the realization that substances are a part of most people's lives. I think it's actually, if we look at it from the continuum, it's 100% of people we work with have experience with substances, whether it's personally or with a family or friend or whatever that might be. And so let's ask questions, let's learn together. I think one example in the Kingston area is we've worked on a harm reduction strategy, and there's been safe needles and different kits. And what's been really, we don't have to have all the answers. There was many staff that wasn't familiar with how to use this. And so here's a shift for us was, instead of trying to learn what the kits are about and the needles, is to ask the people that are using it, because they know more about it than we do. And so let's switch the power, or the education is, it's shared with the people that we work with. and let's use our personal experience, our professional experience, but let's learn from the people that we're working. And I think that's a bit more freeing versus thinking, I need to know. It's hard to keep up with, Sean, with statistics and the research, but let's be experts in delivering the best care, which is taking a step in. Let's be present. Let's witness a person with their life and what they have to offer, and let's listen. And if we could all do that and think of substance use health, then we're going to head in the right direction. I think not leave it, but there's system level considerations, but there's people like Sean and others that are really focusing on this. But every OT on this call, what is your next action to have substance use health as a part of your care? Maybe it is asking, listening, maybe it's going to CAPSA, the website. Well, let's everybody on the call please take some type of action, and then not only do that, but share with a colleague as well. That'll make a huge difference. Sean?
Thank you, Gord. Yes.
And so at the system level, I agree with Gord. We could talk about impact in all the places where substance use health has started to become integrated, from national roadmaps to local organizations that are partnered with CAPSA. I do think I'll take Gord's advice. It's you and punt to everyone else that, yeah, finding that on CAPSA's website and seeing where things are happening large. But, it's nice to think about what you could do. People tell me in all sorts of training I do, whether it's the Stigma Ends With Me initiative or the Compassionate Care Project, one of the ideas is, what can I do? Okay? We don't say move the needle for obvious reasons. We talk about turning the dial where I'm from. And I say to everyone, you do have actually some power to turn a dial. How you conduct yourself. But one thing we can do, and I'm with Gord on this, is we can consider adding the word health after substance use, both in writing and in our common language, and use Signal. Justine starting to get used to that language. And I think it's really important. And one of the reasons I think it's important is because the admission that we're all on the spectrum, as Gord is saying, can be brought to life through the magic of words. And something I'll offer is that if we're all on the same spectrum, there's no reason to discriminate against ourselves together as one people. And what's important about that is that the opposite of stigma, of course, is dignity. And we can't give someone dignity, but we can take it away by overt or, actions that we don't intend, or intentional actions. And so for me, thinking about dignity and thinking about how to do that, and considering everyone's inherent worth and dignity in the way we could and should do, well, the one thing everyone can do that's so simple is just start to practice talking that way. And, you'll find in organizations that don't know a lot about substance use health, they'll say, how come you're saying that? And I'm happy to help if those conversations, if you want to strengthen the nimbleness and ability to have that conversation. But what a conversation we can have. And if we don't believe that the glass can be completely full, then we won't try, right? So.
Oh, I love that. That's a beautiful way to end this podcast. And I just want our listeners to know we have released a 2-page practice document. It's currently titled Substance Use and Addictions, but I am taking that first step, Sean, and adding in the word health today. We will make sure to make that adjustment because it really is a game changer. The language is so powerful. And we know that anyone working in mental health or working in occupational therapy is very aware of the power of language. And it really does change the conversation to talk about substance use health, talking about a spectrum, seeing where you are, engaging in that process of positionality as a clinician prior to working with clients, taking a few moments, checking out CAPSA, checking out the spectrum, and seeing where you are in relation to others. And that gives you your own sense of, where you can bring the conversation with the person in front of you. And I think the systems level pieces are things that we can collectively do through ongoing advocacy efforts, through association work, and even just becoming aware. Those conversations we have with our insurance providers, pushing that envelope a little bit further. And we've seen, I remember during COVID when all of a sudden it became chic for insurance companies to be promoting mental health supports. Prior to COVID, you would never see an insurance company pushing the mental health supports. And, imagine 5 years or less from now that the same thing is being done for substance use health, that they recognize, this is something we can be preventative about. It's something we can be talking to any person about. We don't need to wait for crises to happen. So it's It's been tremendous. I have learned so much from the two of you in this journey, and I'm really, really grateful for this podcast. I know people will want to reach out to you, and we can find both of you on LinkedIn. That's a great way. And yeah, and if you're looking for any other resources, I'd be happy to attach a resource list to this podcast as well. So thank you both for being on the podcast today.
So thank you, Justine.
Yes, thank you.